Hey guys, today I'm going to talk about type 2 LEPRA reaction, also called as Erythema Nodosum Leprosum. If you are visiting my channel for the first time, my name is Dr. Namra Aziz. I'm resident dermatology and I make a lot of educational content. Please subscribe to my channel and hit the bell icon to get notification. You can also follow me on Instagram at Dr. Namra Aziz. First of all, we all should know what are type 2 LEPRA reactions. Type 2 LEPRA reactions represent a small vessel vasculitis, clinical presentation of which is Erythema Nodosum Leprosum. Who gets Erythema Nodosum Leprosum? It affects individuals with borderline leprosy and lepromatous leprosy. It may also occur in a small percentage of individuals with borderline leprosy. Who has a more chance of developing Erythema Nodosum Leprosum? Any guesses? Borderline leprosy or lepromatous leprosy? Approximately 10% of the people with borderline lepromatous leprosy and up to 50% of the patient with lepromatous leprosy will develop ENL. So there is a more chance of developing Erythema Nodosum Leprosum in the patients with lepromatous leprosy. Now, why would somebody get type 2 reaction or Erythema Nodosum Leprosum? Well, there are some risk factors for developing Erythema Nodosum Leprosum. First, like I said before, patient has to be a case of borderline leprosy or lepromatous leprosy in majority of the cases. The mean bacterial index at diagnosis also poses a risk factor. It indicates an individual's risks for developing Erythema Nodosum Leprosum. The odds of an individual with borderline leprosy and a bacterial index greater than 4 at the time of the diagnosis for developing Erythema Nodosum Leprosum is 5 times greater than that of an individual with borderline leprosy and a bacterial index of less than 4. Now, why would somebody get Erythema Nodosum Leprosum or type 2 reaction? The pathogenesis of Erythema Nodosum Leprosum is unknown. It has been known as an immune complex mediated disease for a very long time. There is an exaggerated humoral response. So let's see what will happen in the patient. A patient who has a risk factor for developing Erythema Nodosum Leprosum has exaggerated immune response, thus develops a lot of antibodies. This humoral response is useless because, like I told before in my lecture of leprosy, that Mycobacterium leprae is an obligate intracellular organism and humoral immunity has no role in killing it. So these antibodies combine with the antigens present in the Mycobacterium leprae and form the immune complexes. These immune complexes deposit in the blood vessels and then in different body parts. They specially deposit in the small blood vessels. This type of immunological response is called as immune complex mediated response or type 3 hypersensitivity response. The pathogenesis of Erythema Nodosum Leprosum involves Th2 cells and their cytokines, in contrast to the pathogenesis of type 1 reaction where the main contributory cells were Th1 cells and their cytokines. There is an argument against this pathogenesis. ENL is considered as an immune complex mediated disease because of the evidence of deposition of complement proteins and immunoglobulins in the dermis of the skin biopsies from the patients with Erythema Nodosum Leprosum. However, these studies do not demonstrate the deposition of immune complexes in affected tissues. Newer theories have been proposed to explain the pathogenesis of Erythema Nodosum Leprosum. Now let's discuss some of the newer theories. ENL has been associated with lower levels of regulatory T cells and higher CD4 to CD8 ratios than those found in lepromatous leprosy group without ENL. The increased CD4 to CD8 ratio has been found in both skin and blood of the patient, providing the support for the involvement of T cells in ENL. TNF-alpha appears to be an important inflammatory mediator in ENL, but its role in ENL initiation is unclear. Interferon gamma has been associated with an increased frequency of ENL when injected intradermally in the patients with lepromatous leprosy. Recent gene expression studies have suggested that neutrophil recruitment and complement activation also play a role in erythema nodosum leprosum. How will the patients of erythema nodosum leprosum present? Have you ever thought why it is called as erythema nodosum leprosum? Because the lesions resemble erythema nodosum lesions. When these immune complexes deposit in the blood vessels and the dermis, the patients develop crops of tender erythematous skin lesions, often accompanied by fever and malaise. ENL affects numerous organ systems and is an extremely painful condition. It is crucial that the patient generally feels unwell and has pyrexia. These immune complexes deposit in multiple organs: nerves, joints, eyes, lymph nodes, testes, nose, respiratory tract. Now let's talk about skin manifestation of erythema nodosum leprosum. The typical ENL skin lesion is an erythematous tender papule or nodule. Subcutaneous nodules also occur. Skin lesions may be vesicular, pustular, or bullous. Lesions may ulcerate or become necrotic. Erythema multiform-like skin lesions have also been reported. In rare cases, there may be no skin lesion suggestive of erythema nodosum leprosum. When the lesions resolve, they relieve a grayish-blue lesion resembling a bruise in light-skinned patient, a deep blue-brown or black discoloration in dark-skinned patients. The resolving lesions usually desquamate. Active and fading lesions may be present at the same time. Most frequently, the lesions occur along the extensor side of arms, thighs, on the trunk and on the face, but may also occur elsewhere. They differ in their distribution from erythema nodosum. Sometimes the lesions can be more easily palpated than seen. They feel firm and palpation is frequently painful to the patient. Let's talk about nerve involvement in ENL. Nerve involvement occurs approximately in 50% of the patients of ENL. Nerve involvement in ENL may be severe but is usually less marked than that which occurs in type 1 reaction. Talking about arthritis and dactylitis in ENL, both large and small joints are frequently affected in ENL. Arthralgia is very common, but true arthritis also occurs in more than 20% of the patients with ENL. Distal and proximal polyarthritis has been described. Patients may experience joint inflammation that resembles rheumatoid arthritis with a symmetrical polyarthritis. A false positive rheumatoid factor occurs in the patients with lepromatous leprosy. Erosions on plain radiograph have also been documented. Swelling and inflammation of the digit, called as dactylitis, occurs less frequently. ENL is also associated with lymph node involvement. Lymphadenopathy is usually painful and occurs in approximately 15% of the cases. It may cause diagnostic confusion with lymphoma. Lymph nodes may suppurate. Orchitis in leprosy. Although under-recognized, testicular tenderness and more severe inflammation has been reported to occur in 13% of men with ENL. Swelling and severe pain may occur. Recurrent orchitis due to an ENL has been implicated as a cause of testicular dysfunction in leprosy patients. How does nasal and respiratory tract involvement occur in leprosy? Nasal involvement in ENL occurs in approximately 8% of the patient and may lead to septal perforation. The nose becomes painful and obstructed by edema. Laryngeal involvement in ENL, although very uncommon today, is potentially life-threatening. The symptoms include pain, stridor, hoarse voice, and aphonia. In addition, there are occasional case reports of pulmonary infiltrates associated with ENL, which may cause diagnostic confusion with tuberculosis. Ocular involvement in ENL. ENL is associated with iridocyclitis, which is also called as anterior uveitis or iritis, episcleritis, and scleritis. Ocular inflammation was reported in 5% cases in one of the study. In addition, ENL has also been reported to result in the perforation of the globe requiring enucleation. What other organ systems can be involved in ENL? Hepatosplenomegaly is very rare. However, hemophagocytic syndrome has been associated with ENL. Secondary amyloidosis causing renal impairment was a significant problem in patients with lepromatous leprosy, particularly those who had ENL prior to the introduction of multi-drug therapy. ENL may be associated with nephrotic syndrome and acute glomerulonephritis, but its connection to glomerulonephritis is not clear. Important point to discuss here is that sometimes, especially in borderline lepromatous and subpolar lepromatous leprosy patients, it is difficult to distinguish type 1 reaction from type 2 reaction. They may even occur together or one after another. Some signs and investigations may be of help in differential diagnosis. Type 2 reaction is a generalized disease in which besides skin and nerves, other organs such as joints and lymph nodes may be involved. The patient may be ill. During type 1 reaction, the patient is usually not ill. In ENL, patient may have a raised temperature and ESR, and even have proteins in his urine. The skin lesions in type 2 reactions are mostly tender, whereas in type 1 reaction they are not. Lesions in type 1 reactions may have a sensory loss in comparison with the surrounding skin, while type 2 reaction this is usually not the case. Palpating the lesions in a type 2 reaction, plaques consist of confluent papules and nodules, whereas in type 1 reaction the lesions are more homogeneous. Both type 2 reaction and type 1 reaction may ulcerate, but a smear from the type 2 reaction shows predominantly polymorphs, while that from type 1 reaction shows lymphocytes. Recently, it has been found that the neuroelectrophysiology can distinguish between a type 1 reaction and type 2 reaction. Type 2 reaction may develop a conduction block, where type 1 reaction shows only temporal dispersion. How should the patient with ENL be assessed? Symptoms of fever and skin or other organ involvement result in a wide differential diagnosis, which may delay a diagnosis of ENL. It is important in leprosy endemic countries to consider ENL as a cause of these symptoms in addition to the diseases such as Sweet syndrome, vasculitis, connective tissue disorders. Patients should be carefully assessed with respect to their pain and cutaneous, joint, and eye involvement. Particularly, it is very important to ask about nasal and testicular symptoms as the involvement of these organs is often overlooked. Peripheral nerve functions should be carefully assessed and monitored at each visit using monofilaments and voluntary muscle testing. Now let's talk about management of ENL. The management of ENL can be challenging due to the often chronic nature of the condition and adverse effects of treatment. Hospital-based studies show that the majority of the patients with ENL have a chronic disease which can continue to cause problems for many years. It is also important that the patients with ENL and their relatives be given information about ENL and its management. Importantly, polychemotherapy should be continued throughout the reactional episode, whether it's ENL or reversal reaction. Can running some labs give us a clue? Laboratory tests frequently demonstrate an elevated leukocyte count, low hemoglobin and hematocrit. Elevation of liver function test and serum C-reactive protein may also be observed. The prevalence of ENL has been reduced after the addition of CLOFAZAMINE in multi-drug therapy of WHO, suggesting its protective role. I'll talk more about CLOFAZAMINE in a while. Mild reaction without neuritis, ulceration, or any other severe system can be managed with supportive care. Corticosteroids and thalidomide are still the mainstay of treatment. Severe type 2 reactions with neuritis and systemic symptoms require prompt treatment with corticosteroids to avoid permanent nerve damage. Prednisone 40 to 60 mg per day should be started and quickly tapered over a period of 2 weeks when the reaction has been controlled. In the absence of clinical response, higher doses of the prednisone Roughly 1 to 2 mg per kg per day of steroid, that is prednisone, will be sufficient. A relatively short course may be sufficient, but the reaction recur and intermittent symptoms may continue for a year or more. If prolonged therapy will be needed, in such cases, transitioning prednisone dosing to an every other day schedule may diminish the side effect of steroids. Or other options of the drugs, for example, thalidomide, can be utilized. Talking about thalidomide is very effective in treating type 2 leprosy reaction, but teratogenicity limits its use in women of childbearing age. Of note, the efficacy of thalidomide in treating type 2 reaction is only reason it has not been completely banned. Thalidomide is administered initially in a dose of 300 to 400 mg per day. Frequently, this regimen controls the reaction within 48 hours. The dose is adjusted according to the symptoms and adverse effect. Subsequently, the dose should be tapered to a maintenance level, generally around 100 mg per day. Every month, attempts are made to taper off the drug. To control Erythema Nodosum Leprosum, thalidomide may be continued for several years. Development of neuropathy should prompt immediate discontinuation. Clofazamine is not useful for the management of acute type 2 reaction, but may be of value in chronic cases. Gastrointestinal complaints may limit the use of higher doses. The clofazamine component of multibacillary regimen may have a protective effect in preventing reactions, since type 2 reactions appear to have become less after the introduction of multi-drug therapy. Like I said before, clofazamine is recommended in the treatment of chronic recurrent reactions. Clofazamine is administered for 12 weeks together with corticosteroids at a dose of 300 mg per day for 12 weeks, which is then reduced to 200 mg per day for another 12 weeks, and then 100 mg per day for 12 to 24 weeks. Clofazamine is less effective than steroids and takes 4 to 6 weeks to be fully effective. Addition of clofazamine to the therapy is extremely beneficial in reducing corticosteroid doses or discontinuation of corticosteroid therapy in the patients who have become dependent on corticosteroid. The total duration of the clofazamine should not exceed greater than 12 months. At the doses mentioned above, the drug often worsens clofazamine pigmentation, which may be unacceptable for some patients. Furthermore, there is increased risk of clofazamine crystal enteropathy and possible cardiotoxicity at larger doses used to manage ENL. Pentoxifylline has shown to reduce the production of TNF both in vitro and in vivo. A randomized controlled trial in which 1.2 gram of pentoxifylline was administered daily for ENL demonstrated that it was not as effective as 300 mg of thalidomide administered daily. In addition, it was associated with significant rates of adverse effects. Cyclosporin at an initial dose of 7.5 mg per kg per day compared to prednisolone showed promising result in a small double-blind randomized controlled trial. However, it did not appear to have impact on 10 chronic patients of ENL. Methotrexate is also used to treat ENL. There are 3 case reports of oral methotrexate being used to treat ENL at initial weekly doses of 7.5 and 15 mg. The use of azathioprine for ENL has been described in case reports and case series. A pilot study of 100 mg of minocycline administered daily to 10 patients with prednisolone-dependent chronic ENL has shown promising result. However, minocycline-induced pigmentation occurred in all patients. Role of biologics in ENL. The chimeric anti-TNF-alpha monoclonal antibody infliximab and recombinant TNF-alpha receptor fusion protein etanercept have been used to treat ENL in 4 individuals. Now let's talk about some other drugs which are also used in the treatment of ENL and have limited efficacy. Chloroquine therapy is occasionally used to manage ENL, but there is little evidence from the control study that it is effective. The leukotriene antagonists zefirlocast at a dose of 40 mg twice daily was effective in 6 patients with ENL, although outcome measures were not identified. Colchicine has been used to treat ENL but appears to have limited efficacy. Oral zinc has been used in 2 small uncontrolled studies. Finally, levamisole given on 3 consecutive days monthly for 3 months was found to be ineffective. Thank you so much for watching my video. Please make sure you subscribe to my channel and follow me on Instagram at Dr. Namra Aziz.